Ladies and gentlemen, hello, this is Daniel Dürschmied. I'm a cardiologist and intensivist here in Freiburg in southern Germany. And it is a pleasure for me to discuss whether there is a place for hemoadsorption after cardiac arrest. These are my disclosures, and I'll give you a moment to have a look at them. Now, I think that there is a place for hemoadsorption after cardiac arrest. And the reason is that many of the patients who will have a return of spontaneous circulation will go into post-cardiac arrest syndrome. And it's especially the patients that were resuscitated for a longer period of time. And the general ischemia during cardiac arrest and the subsequent reperfusion by ROSC induces an increase of reactive oxygen species. It triggers inflammatory cascades, and it induces mitochondrial dysfunction, which all lead to blood vessel instability, cell death, and brain swelling. And what we can observe in patients with post-cardiac arrest syndrome is a cytokine storm, and it's notably pro-inflammatory mediators that are increased in the circulation of these patients, such as procalcitonin, interleukins, TNF, or other cytokines. So I believe that there is a massive cytokine storm in post-cardiac arrest syndrome, and that it may make sense to target the cytokine storm by hemoadsorption. And the device that has been used most frequently is the CytoSorb adsorber device that is known to adsorb many of the pro-inflammatory, also some of anti-inflammatory cytokines. It adsorbs many others. That is a process that will be delineated in some of the other talks here at ISICEM. So which patient will go into post-cardiac arrest syndrome? And I will discuss a few extreme examples here. The patients that do not achieve ROSC despite prolonged cardiopulmonary resuscitation. And it's the patients that we will then offer extracorporeal CPR by the introduction of a veno-arterial ECMO circuit. And whether this is being done in the Louvre, as has been published before, in a metro station, or just a regular street here in Freiburg, all of these scenarios will trigger a post-cardiac arrest syndrome with a massive cytokine storm. And we have measured the cytokine storm in a number of cases, and I will show two cases to you here in the two following slides. So this is an 18-year-old male patient who collapsed during soccer playing. He could not be resuscitated despite ongoing CPR for more than 60 minutes before VA ECMO was implanted. And we also implanted an impeller. And despite this, we observed an increase in lactate with peak levels above 15 millimoles per liter. And we also observed a massive increase in interleukin-6 with values as high as 18,500 picograms per ml. So we also introduced the CytoSorb device 3 times 24 hours in this case. And we observed an improvement in clinical course and also a rapid decrease in interleukin-6 levels. This is another patient, 59 years old, where we observed very high levels of interleukin-6 after eCPR with the ECMELA approach. Interleukin-6 levels were higher than 22,000 picograms per ml and dropped rapidly while the patient improved with ECMELA and also cytokine adsorption. So now let's take a step back and have a look at outcomes in eCPR. And I want to draw your attention to a very recent paper that describes data from 5 European eCPR centers, and the authors found a 19% favorable neurological outcome in 3 months, despite mean time to VA ECMO of more than 60 minutes. And I think this is remarkable because if you imagine a patient without ROSC for more than 60 minutes, you will rarely have survival, and very rarely you will have neurologically favorable outcome at 3 months. And 19% is a rather high rate, I would suggest. The authors also applied more stringent selection criteria to define a more favorable cohort within the ECPR patient cohort, and they found a more than 30% favorable neurological outcome in these patients. And I want to show you some data from our center, a recent report that we published in Scientific Reports. And this is our algorithm for patient selection in ECPR. If a patient collapses and despite advanced life support does not achieve ROSC, within 15 minutes, this patient will be evaluated for ECPR. And there's a number of pro factors and con factors that we will have to weigh in this setting, such as signs of life during resuscitation, which will inform us in favor of performing ECPR, or for example, no flow time, no CPR for more than 80 minutes, which will inform us rather against performing ECPR. And all of this leads to a selected patient cohort. And we have analyzed our data here at our center. 252 patients were included, 112 with out-of-hospital cardiac arrest and 140 with in-hospital cardiac arrest. A surprisingly high rate of myocardial infarction as the primary cause of cardiac arrest in this selected patient cohort. And the survival to hospital discharge was also rather favorable, despite more than 50 minutes until VA ECMO implantation. And this hospital survival rate was approximately 30% in OCA and also in ICA patients. We followed up these patients, or a number of these patients, for a longer period of time and found that neurological outcome in survivors after discharge was also rather favorable. And we defined favorable outcome by cerebral performance categories 1 or 2, which basically means that these patients were able to work afterwards. And if you have a look at the figure on the left, it shows you that most of the patients had favorable outcome, even for very long periods of time, for even more than 6 years in some of the cases. We also sent out questionnaires, the SF36 questionnaire, to our patients and found that their functional rehabilitation was well, and they felt rather well, almost like a regular population of the same age. So ECPR can work if you have a selected patient cohort, but 30% of course is not enough. So we want to further improve survival, and cytokine adsorption, hemoadsorption may be one way to further improve survival. Now, this CytoSorb device can be incorporated into the ECMO circuit quite easily, so the technical setup is not complicated. And we have analyzed our registry data and found 23 patients treated with ECPR who also received the CytoSorb device during their treatment course on the intensive care unit. We matched these 23 patients to 23 other patients undergoing ECPR, but without cytokine adsorption. Propensity score matching was performed according to the parameters sex, age, and time from collapse to VA ECMO. And you can see here that the cohorts were rather well matched, except for the duration of VA ECMO therapy in total, which was 5.4 days in the CytoSorb group and 2.6 days in the group without cytokine adsorption, suggesting that the cytokine adsorption group was a more complicated patient cohort. And you can see the results of these registry data analysis here. This is the Kaplan-Meier curves of survival, and the survival rates were similar in both groups, with 17 and 21% over time. But if you have a look at the earlier days after ECPR, there was a trend towards better survival during cytokine adsorption. We also measured a number of parameters in both groups. The platelet count and prothrombin time were very similar in both groups. And also lactate volume balance or vasopressor use were not statistically significantly different, but there was a trend towards better performance in the cytokine adsorption group. We measured interleukin-6 levels in the cytosorb group only and not in the control group because this was done retrospectively, and you can see a significant decrease of interleukin-6 levels during cytokine adsorption. So we believe that hemoadsorption in ECPR works and that there may be a benefit for the patients. And we thought that it was time to start a randomized controlled trial. We called it the CYTO trial, and we'll be focusing on hemoadsorption in ECPR because we believe that all ECPR patients will develop post-cardiac arrest syndrome with massive cytokine storm. We started our trial in 2019 here in Freiburg. We include patients in this trial with persistent cardiac arrest who will undergo extracorporeal CPR, and we will randomize these patients on site to either receive VA ECMO with cytokine adsorption, and we will use 3 devices for 24 hours each, or randomized to VA ECMO without cytokine adsorption. Our primary endpoint will be interleukin-6 levels at day 3, and we will have a look at a number of secondary endpoints, surrogate parameters, and also clinical outcome. And I would like to show you some of the preliminary data. This is the primary endpoint, interleukin-6 levels at day 3. And the control cohort experienced a 50-fold increase of interleukin-6 at day 3. And this was drastically reduced or prevented by cytokine adsorption in the cytosorb group. Let me point out to you that there is another trial investigating cytokine adsorption in cardiac arrest. And this is performed in Lausanne by my good friend and colleague Antoine Schneider. And they call their trial the CATCH trial, and they include patients undergoing conventional cardiopulmonary resuscitation. They also started trial enrollment in 2019. And patients will be included into this study if they have ROSC after conventional CPR, but if they have ongoing post-cardiac arrest syndrome, will then be evaluated for inclusion into the study. Patients will be randomized to hemoperfusion plus cytokine adsorption for 12 to 24 hours, or no hemoperfusion with cytokine adsorption. The Lausanne colleagues will also measure cytokine levels at day 3 as primary endpoint, and have a look at a number of secondary endpoints as well. So in conclusion, I hope to convince you that hemoadsorption may have a role in cardiac arrest. I believe that hemoadsorption with the cytosorb device in CPR, and I have shown you a number of data points from eCPR, was associated with no severe complications, with a decrease in surrogate parameters, and with an improvement in the clinical course in several cases. And we believe that this is the rationale for now starting to randomized controlled trials, one enrolling eCPR patients, the CYTO trial, which we perform here in Freiburg, and the other one, the CATCH trial, will enroll conventional CPR patients with post-cardiac arrest syndrome, which will be conducted in Lausanne. This is it for now, everybody. Thank you very much for listening. Thank you for your kind attention, and bye-bye.